So I'm here at RANZCOG 19 with Sawsan As-Sanie, who just presented on pelvic pain as part of a huge plenary on the topic, where we sort of really heard about the importance of multidisciplinary management. You had 7 take-home messages for people in your talk. Could you talk me through them?
Good memory. So, it was a fantastic program that brought in all of the disciplines that are incredibly important in the evaluation and management of pelvic pain. It was really exciting to hear from a physiotherapist, a pain psychologist, as well as all the incredible research that's going to be happening here in Australia on pelvic pain. In terms of my take-home messages, I would say that probably one of the most important is that chronic pelvic pain is a symptom, and there are many different pathways that can lead to chronic pain in women, and so it's really important for us as gynecologists to have a multi-system, multimodal evaluation and management approach to pain. So we need to think about not just what the reproductive organs are doing that could contribute to pain, but we need to think about the bladder, the intestines, the musculoskeletal system, the central and the peripheral nervous system, and see how they all interact that could potentially cause pain. There are many different pathways that any given patient can take, and once a woman suffers from pain, she's more likely to develop new causes for their pain, especially if there's not intervention at an early time. Some other take-home messages, now I feel like I'm being tested. What did I say? So, hysterectomy is not a cure for all women. It can be helpful for many women, but not all women. There are a multi-system approach to pain, and so pharmacologic therapy, behavioral therapy, and interventional treatments such as surgery should be selected, based on what is appropriate for any given patient and through a shared decision model for pain. You're going to have to remind me. What else did I talk about?
One of your big messages was
yes.
No pain without the brain.
Yes, yeah, absolutely. Of course, that's my biggest take-home message is that, the more modern approach and interpretation and understanding of pain is not just an input of what is happening in the body, but it's actually an output of the brain processing, what are the relevant signals that are coming from the body, as well as how the brain is either able to turn down or turn up the signal on pain. And so it is a normal protective, factor to our environment. But in patients that suffer from chronic pain, there's often some type of dysfunction in that central nervous system that either lacks the ability to turn off the volume or turns it up in some way. And so in patients that have chronic pain, they often have these characteristics of centralized pain where there's a problem in the central nervous system in the processing of pain information. And so the common symptoms that we see in these patients include not only chronic pain, but the pain often tends to be widespread. Patients suffer from sleep dysfunction, they suffer from fatigue. Some patients even suffer from cognitive dysfunction and memory loss. And so recognizing that as a subset of what might be happening in some patients with chronic pain, deserves, high priority as well as a very specialized approach to these patients.
How well do you think this is recognized, and how well is this condition managed?
I think, there's definitely increased recognition, in many healthcare settings, but I think there's still a lot of work, to be done. Just in and of itself that this is, this topic has been selected as one of the plenary sessions and, one of the largest ONG, conferences in the country, I think really speaks volumes to the increased recognition, but, getting this to general providers, to the practitioners out in the community, I think there's still a lot of work to be done, but this is a great first step.
And we've heard a bit this morning about the psychological elements of it as well. What was your takeaway from that?
Well, I think that it's a really important factor to recognize that patients with chronic pain often have a lot of psychological distress and dysfunction, higher levels of anxiety, high levels of depression, higher levels of maladaptive coping behaviors. Many of these are a consequence of living in chronic pain for a long time, as well, particularly chronic untreated pain, and really helping patients to get the resources to both understand how this contributes to pain and how treating it in parallel with any anatomic as well as physiologic causes of pain is incredibly important. And so our colleagues talked about a lot of really important resources that are available to both practitioners and patients in addressing this really important parallel problem.
And you said that gender bias and women's, I guess, experiences in the health system are still a problem. Can you touch on that?
Well, I mean, what I think is really important for us to recognize as a society is that for a long time there's been a dismissal of pain, particularly menstrual pain, being normal in women. This is what everybody experiences. Brennan Barrett worked through it, and not necessarily recognizing when this is actually a symptom of something that is very treatable. I mean, all menstrual pain is treatable, and getting patients to be heard and getting providers to recognize that this is, a very important problem to deal with.
And just finally, you had a stop, start, continue at your end. What were your messages at the end of your talk?
Well, I think that chronic pain is a symptom, and that having a multimodal, disciplinary approach is important, that we need to recognize that the brain is a powerful player in the perception of pain, and treating centralized pain, learning how to recognize and treat it in a multidisciplinary fashion is incredibly important.
Thank you so much for your time.
Well.